Okay, we're going to talk a little bit about pre-hospital. I've got you twice this morning, one to talk about cardiac stuff and one to talk about trauma care in the pre-hospital setting. And there are actually some very interesting articles. A lot of stuff we probably already know if you're a 911 receiving center, but some also interesting things that I learned. The first thing is that obviously everybody knows that EMS developed a number of years ago, 30 years ago, probably 40 years ago now, for actually resuscitation of cardiac patients. That's why it came about, was to help the cardiac arrest patient. So if you're going to do any successful resuscitations or saves of people that have an arrest in the field, you have to have a good pre-hospital setting. Second point, Billy Malin actually wrote the chapter on trauma. And for cardiac, the other thing that it's interesting is something called the Utstein template, which is not something if you don't do research, you don't need to know about it. But basically, it's kind of a standardized way of reporting research in pre-hospital setting, whether it's resuscitation, trauma, cardiac. And it basically talks about the universal or the universal clock, which is, you got to talk about minutes from the time the paramedics pick up the patient, the time the first provider sees the patient, every minute along the way, and kind of every step along the way, patient's intubated, the IV fluids, what lines were started, and really kind of point by point in regard to the data that needs to be collected if you're going to do any real good research and be able to tell other people about it and compare study to study. And last point was that just in the last 5 to 10 years, we've had really good research in regard to EMS. A lot of it before was one EMS center would do one type of care and another EMS agency would do another type of care. And it really was kind of the direction of the medical director with really not a lot of good hard data. And now we have a lot more studies saying what should and shouldn't be done in the kind of the pre-hospital setting. So the first article was basically on the use of motorcycles. And this was out of Portugal. And I could see this being in Los Angeles where it can take forever to get from point A to point B. And the paramedics on the ground can't get from point A to point B in the middle of rush hour. So what they did was they deployed a medical emergency motorcycle. An oxygen on it, an O2 tank, AED, basic airway equipment, a glucometer, and first aid. Not much, but a lot of BLS kind of stuff, plus an AED. They dispatched an ALS or BLS ambulance to a lot of these scenes in addition to the motorcycle. 2/3 of the time, the motorcycle made it there first. They saw a variety of patients. Medical complaints were about 40%. Trauma was about a 5%. They gave oxygen half the time. They immobilized. They controlled bleeding. They actually used the AED 1% of the time. Their average arrival time was about 4 minutes, compared to a lot longer time for the BLS or ALS ambulances to arrive. And 2/3 of the time, the motorcycle was actually the first to arrive. So this is not, I wondered why Billy actually put this as the first article. And he rides a motorcycle a lot to work, so that's probably why he liked it. The next few articles actually talk about cardiac arrest. And we all know that Seattle is the place to be if you're going to have a cardiac arrest. Los Angeles, we'll talk about the article, basically says don't be there if you're going to have a cardiac arrest. Some people say, why is Seattle so good? They have good EMS. They have a lot of good re-education of their paramedics. They have short response times. They have widespread use of AEDs. I think they're in every Starbucks out there. It's apparently a high school requirement. Anybody from Seattle? But according to the chapter, it's a high school requirement that you have to have BLS as part of your training or part of your high school graduation. You have to have that as probably part of your health classes. And they think because a lot of the caffeine, at least Billy's thought, is a lot of caffeine up in Seattle, you're already set up for having good resuscitation of your arrest because you've got caffeine floating through your body. Mark Eckstein, who's in our department, is LA City EMS medical director. He looked at arrest records or outcomes from 2000, 2001 for cardiac arrests in LA County, and we didn't do nearly as well as places like Seattle. Neurologically intact patients was about 1.5%. They looked at 1,700 pre-hospital cardiac arrests, not trauma-related. You did better if there was bystander CPR, which we know. You did better if you were VFib or VTAC arrest, pulseless VTAC. And you did better if you actually arrested in front of the paramedics. So if you had a pulse and then you lost it, you actually did a lot better too. But we had no differences compared to Chicago and New York. Obviously, Seattle is still the place to be. What about the answer if you go home neurologically intact? What does that mean? What is your kind of outcome? Article number 3 looks at this. Is in Rochester, over 200 patients, again, cardiac arrest. They were VFib. They had an AED used on them, so you're much higher success rates. You're much more neurologically intact patients. 72% of them survived to admission to hospital. About 40% were either neurologically intact or had some type of moderate disability. Their 5-year survival after this event was about 80%. And this is the same if you took the same group of patients who didn't have a cardiac arrest, same age, same gender, same type of past medical history. Their outcome for 5-year survival wasn't that much different, which is interesting. They then have the survivors rate their quality of life. And pretty much, again, it was pretty much the same compared to the same group of people that had not gone through a cardiac arrest. The return to work was about 58% for survivors, and if they were less than 65 years of age, it was even higher. So if you get somebody back neurologically intact, they can actually go on and have a fairly successful life. What about the idea of withholding ALS? We bring a lot of people to the hospital. You know, the 95-year-old woman who's in a nursing home who hasn't talked in 20 years, she's been bedridden forever, she's got a G-tube, and yet we feel the need to give her a round of ACLS and get her intubated. Unless she's got a full DNR, we do a lot of stuff at the end of someone's life that probably is not warranted and costs, you know, a fair number of bucks. And when we don't have, you know, healthcare dollars are limited, should we be spending that amount of money in the last few moments of someone's life? So article number 5 looks at the issue of whether EMTs with an AED can decide to terminate, interesting issue, whether they can decide to terminate a resuscitation. So they deployed about 1,200 patients. They were cardiac arrest. The vast majority were men and older. They had the EMTs roll out with an AED, and then they followed their own protocol with the AED. They did compressions. They did, they shocked the patient if the machine said to shock. They did a reevaluation of the pulse. They went through their protocol. They decided to terminate the event or terminate the resuscitation if 3 things happened. 1, if the machine never said to shock the patient was clearly dead. There was no return of spontaneous circulation. Or if later in retrospective review, if there was an unwitnessed event, because apparently the patient had been down long enough that they weren't going to be resuscitated. The machine or the protocol basically said to terminate about 2/3 of these arrests. When they looked at the patients who then, under this termination protocol, 4 of them actually survived. This was about 0.5% of the patients that the EMTs would have terminated. 4 of them survived. 3 of them were actually neurologically intact. 3 of the 4 had kind of good neurological outcome. They said their threshold for just doing this study was about 1%, meaning a medical futility. They were willing to accept, if the machine or the protocol said to terminate, they were willing to accept about a 1% chance of the patient being actually resuscitatable in this study. And theirs actually came out less than this, so they thought it was okay. If they then added in that EMS arrival was greater than 8 minutes, so not only you had one of these 3 protocols, plus it took the paramedics or the EMTs more than 8 minutes to get there with the AED, it brought the survival for termination down to even less, about 0.3%. So they said, you know what, it looks pretty good. EMTs actually could decide in the field whether or not to terminate. What about the performance of CPR? The big thing now, as you probably know, is just compressions. Not for us in the ER, obviously, but for the lay people. And I've heard this for many, many decades now. 20, 30 years ago when I was starting to do this, the big thing was if the family member or a bystander did anything to the patient, threw a chair at the patient, their chance of recovery was much higher. And we now know this is true. Patients, family members, bystanders don't need to do the mouth-to-mouth part. They really just need to do the compressions. In fact, the American Heart Association, it used to be that you had to go to a 4-hour class for lay people. Who wants to go to a 4-hour class, especially a lay person, to learn about CPR? Well, the new thing now is this kind of family and friends CPR. You guys have probably heard about this through the American Heart. It's relatively recent. And it's basically a 20-minute class that you can do in the comfort of your own home. And I actually bought the kit online. It comes with a whoopee cushion-looking mannequin. You basically blow it up. It's got a DVD, and it's a 20-minute class that you can do at home. And their thought, thank God American Heart finally dawned on the fact that people don't want to go to a 4-hour class. Why not have them learn this in their home? And again, the big push is just compressions. In fact, I just bought 2 of the mannequins, and I'm going to do a potentially research project in our ER for the families that are waiting around to see a doc, especially in my pediatric ER. Why not give them the chance to learn a little bit about CPR, especially if we're just pushing the kind of compressions attitude, or compressions component of it. Article number 6 looked at this issue of just doing compressions compared to doing regular CPR, which involved airway also. This was out of Japan, 4,000 of adults with cardiac arrest. Obviously, it was not randomized. They just looked to see what patients had done to them in the field. Some people got compressions only. Some people got regular CPR with mouth-to-mouth. And some people got nothing. Almost 3/4 of the patients actually got nothing. They then looked at 30-day outcome. About 10% got compressions only, and about 20% actually got regular CPR. When they looked at neurological outcome, patients that got bystander CPR did more favorably than the ones that didn't. That obviously makes sense. But the patients that got compressions only, and this is one of many studies to show this, did just as well as the people that got mouth-to-mouth. And that's why the American Heart has kind of adopted this attitude of compressions only. Just do compressions. If the patient was apneic on arrival, again, when the EMS finally arrived, again, patients that had gotten compressions only did better than the patients that had gotten compressions plus any type of mouth-to-mouth. Patients that were in VFib, VTAC, same thing. Patients who got resuscitated within 4 minutes of their downtime also did much better if they just got compressions. So the big thing now from the American Heart you'll probably see is the fact that, at least for the pre-hospital setting, for bystanders, is compressions only. Obviously, we still have to deal with airway and breathing. Article number 8 looks at the idea of the big thing also now with the American Heart is we spend too much time not doing CPR. The big thing now is keep your hands on the patient. Continue to do CPR as much as possible. The idea of stopping CPR and analyzing for a pulse and analyzing for a rhythm as much as we do now is old. We really need to increase the amount of time, of contact time that we have with the patient doing CPR. So this was a study where they compared 134 patients that had AEDs and historical controls that had gotten the old way. So the old way was doing some CPR and then stopping and giving a shock and then seeing if there was a pulse. There was a lot of downtime of not doing CPR. And in this situation, for the new protocol, they said we're going to shock the patient and then immediately do 2 minutes of CPR. We're not going to check for a pulse. We're not going to check for a rhythm. We're going to do CPR for 2 minutes and then we'll check. If they still don't have a rhythm, we'll shock them again, do immediate CPR for 2 minutes, and then check. So that was a change in the protocol. So they compared new protocol to the old protocol and basically found a pretty good difference. The proportion of time that patients got CPR between shocks, and the big thing now was more CPR, was much longer, much better with the new version compared to the old version. The return to spontaneous circulation with the new CPR, which was more contact time, more chest compressions, was 74% compared to 60%. Able to be hospitalized, they made it to admission. New CPR was 46% compared to 33%. And discharge home, again, new CPR was 37% compared to 26%. So the big thing is stop analyzing rhythms, stop checking for pulses, shock the patient once, do CPR, and then analyze whether or not the patients had some type of result. Article number 9, there's all sorts of machines that can check to see how deep you're going, how fast you're going, how much contact time. And again, I don't think every ER is going to get one of these things that will give you real feedback time in regard to how you're doing your CPR. But I think the message from article number 9 we can come away with. This is an article out of Norway. They took 60 cardiac arrest patients, and they evaluated not only for the depth of the CPR, but the duration, how much they had hands off, how much time they were not doing CPR. And so they had not this kind of specialized monitor defibrillator. And what they found was that the more time they spent off the patient, the worse the patient did. And the less compressions, the not as deep compressions, the patients did worse. For every 5-second decrease in pausing with CPR, so if you did CPR a lot more often, for every 5-second decrease in pre-shocking pause, so hands off, let's shock the patient. We all stand around waiting for the thing to, churn up or to rig up, that was detrimental to the patient. So for every 5-second decrease in pre-shock pause, the odds ratio for a successful shock was better. So the more time you spent doing CPR, the less time you spent with hands off, the patients did a lot better. For every 5 millimeter increase in depth, so the deeper you went for CPR, the patient also did a lot better. So faster, deeper, and don't stop. Some men in the audience have probably heard that. Was much better. That's the way you got to think about it. Faster, deeper, and don't stop. Article number 10 looked at the issue of doing CPR prior to shocking. Some people think if you arrive on a cardiac arrest patient, maybe you ought to give them a little bit of circulation. Get the blood flowing before you shock them. Whether or not this is beneficial or not remains controversial, but what we'll find from this article is the longer the downtime before you arrive to the patient, the better it probably seems to do a little bit of CPR before you give them a shock. So this was out of Norway. These were adults that were either in VFib or VTACT, and they were randomized to either standard resuscitation, where they arrived and they shocked right away, versus they got 3 minutes of CPR before any shocking was done. And they really, they really found no difference between ROSCE and survival unless the arrival times were longer. So once they got to where the response time was upwards of 5, 7, 9 minutes before a responder arrived, those patients actually did better. The odds ratio were higher for successful resuscitation if they had some CPR done. A minute or two, it doesn't seem like response time, it didn't seem like adding CPR did anything. So for us in the ER, again, patient arrests right in front of us, we need to resuscitate, we need to shock them right out of the rhythm. But if somebody arrives in the pre-hospital setting, someone's been down for a while, their response time is longer, doing a little bit of CPR prior to the shock seems to be helpful. Article number 12, again, CPR devices. If you probably over the years have seen various versions of ways of giving patients cardiac compressions rather than good old just hands on a chest, right? We had the plunger method. There's a couple articles looking at this thing called the auto pulse. If you look in the internet and under the Zoll web page. It's basically this kind of band that goes around the chest that compresses the chest from here to here and kind of brings it. They said it has a 20% reduction in the AP diameter of the chest, and it'll give about 80 compressions a minute. I think they only have it for adults. I don't think they have it for kids. And they said, you know what? We're going to have better cerebral flow, better coronary flow. Well, do we? So article number 12 and article number 13 both look at the same, both published in JAMA in the same month, both looking at the same device. Article number 12 was a multi-center study. They randomized 1,000 patients to either manual CPR or the use of this auto pulse kind of vest jacket. They found really no difference. They found actually worse outcomes with this auto pulse thing compared to just good old manual CPR. And they actually discontinued the study early because the patients, those who had good neurological outcome, were actually worse if they got the auto pulse. So they stopped the study early. This was a multi-center study. Article number 13, same machine, same manual CPR versus this new auto pulse. They actually looked at a retrospective group of people that had gotten manual CPR compared to the new patients that actually had gotten the auto pulse jacket put on, and they actually found better outcomes. Well, how do you explain that? You have two different studies basically showing very, very different results. Article number 4 was by Lewis out at Harvard UCLA. They looked at the two studies and said, well, what's up? Why are we getting two such greatly different outcomes? Article number 1, again, being a single site, had much higher survival rates. Article number 2 was the multi-center, where it was randomized, had lower survival rates, and they actually had stopped the study early. They said, well, for one thing, in the multi-center study where it was randomized, they said there's something could be called the Hallstrom effect, Hawthorne effect. Hallstrom was the author. Hawthorne effect, where because you're being watched, you do things better. So because these people knew possibly that they were in a study looking at manual CPR compared to this auto pulse, the people that were doing manual CPR did it better, and therefore they had better outcomes in their manual CPR group. That's one thought. Increased deployment time when the device was used because they had to get the device to the patient. And enrollment bias. They weren't continuous patients that were being enrolled. They were kind of picking and choosing. The EMS guys were allowed to pick and choose which patients. So maybe if they went to the 94-year-old grandma in a nursing home who hasn't, again, been bedridden for 10 years and hasn't talked in 20 years, they probably said, you know what, let's not waste the device on this one. Let's just do manual CPR in her. Versus the 40-year-old cardiac arrest guy in an office building, they said, hey, let's do the auto pulse on him. So a little bit of bias in there. And just because you look at two cohorts of patients and you try to say, look, they're equal, retrospectively, they're equal in their age and their gender and their degree of illness and past medical history, there's some things that'll be different between the two groups that you're not going to know about. So those were some of the reasons that they said you're going to see a difference in one study versus another, even though it looks like the machine is being used the same. So they said, don't jump on a machine or a new device, because every company is going to come out with, here's a new device that's going to make CPR a little better. The standard of care is still good old, hands on the chest, good CPR, and like we talked about, it's deeper, faster, and more contact time. Don't stop the CPR. Very limited time should be stopped in CPR. In fact, that's the research project I wanted to do at our hospital, is to videotape our full arrests and then have them watched later. And I bet, even at C Booth, where we do this all the time, I think our contact time and actual hands on the chest is going to be, it's going to be an eye-opening experience, I think, for a lot of us watching our own resuscitations, that we're not kind of doing what we should be doing. Article number 15, just as a reminder, if the patient has an internal defibrillator, be careful, because you can actually get shocked by the defibrillator if you're doing CPR. And this was just a case report of a provider who was doing CPR and the device went off and he got shocked. How do you guys make it so it doesn't shock you? What do you have to do to the defibrillator? Put a magnet over it and it should disable it, at least while you're doing the CPR. So what about AEDs, the public defibrillators? I think we all would argue that defibrillators having defibrillators in the public community has been really good. It depends on where you want to put them. Where are you going to get your biggest bang for your buck? We know this, right? Airports, potentially, casinos, places where maybe nursing home, retirement, not nursing homes, but retirement places, kind of the seizure world, we call them, the leisure worlds of the world, where there's a bigger cohort of patients who are more elderly, have medical problems, who are more likely to arrest. One place I heard wanted to put them on school buses. They won't put seatbelts on school buses, yet they'll put AEDs. And nobody knew if the bus driver was going to defibrillate the children, or were the children going to defibrillate the bus driver. In fact, my old hospital that I worked at years ago, the in-hospital arrest record for the Department of Medicine resuscitating people was so bad that the CPR committee wanted to put AEDs inside the hospital on the floors because they couldn't trust the Department of Medicine to run resuscitations correctly. They couldn't read rhythms. We thought, how about putting an ER doc on the code team? No, that wouldn't. They were going to put AEDs in the hospital. Crazy. So Article 16 looks at the issue of AEDs, and they looked at 993 community units. They basically looked at places where there were recreation facilities, shopping malls, and they trained a bunch of volunteers in these various areas on good CPR. And then they gave them half of them also AEDs. So you either got CPR at these places, or you were actually having access to an AED. And what they found was they rolled out on about 500 cases. 235 of them ended up being really cardiac arrests. A bunch of them were like slips and falls and faints and things like that. About half got CPR, about half got CPR plus AED. What's interesting is more of the volunteers who were trained jumped in and did things if the AED was around. I think because they thought, oh, it's going to be fun to learn how to play. Who knows why, but more volunteer response was found in the group that got AED. Their survival to discharge, again, much higher. We all know this if an AED was available that was used on these patients. Article number 17, the next ones are just basically observational studies saying that in Las Vegas, you have, especially if you had VFib or witnessed VFib arrest, your survival was much higher. In Chicago, this was out of airports. They had 26 arrests. 21 of them were real, 4 were not. 1 was related to trauma, but of the 21 real arrests, 18 were witnessed. 11 survived, and of those 11 survived, 11 were neurologically intact. They gave an amount, cost per life, of about $7,000. Article 19 was out of Scotland. Again, airports, over 7 years, they had 38 arrests, really good outcomes. They said it cost about $61,000 for quality of life. Again, it depends on how you rank the numbers and how you come up with this cost. And then it's, everybody's opinion about where we should be putting these things. You guys all know that Tim Russert died a couple weeks ago. I am sure NBC has AEDs everywhere throughout the building now, because a lot of people think he had a sudden cardiac arrest. If he had an AED available, he might still be here, and we would be talking about AEDs in buildings rather than coronary disease, silent coronary disease, that type of stuff. So we would be having a completely different conversation if he had been resuscitated. What about monophasic and biphasic? How many of you guys have converted over to biphasic? Probably most places have gone to biphasic. And the funny thing is there really isn't any evidence that they're any better. The thing that was better, and remember the monophasics deliver energy, and I'm not a physicist, but deliver energy in one direction versus biphasics give it in one direction and then backwards. Apparently it takes less energy to do that. So your machines are smaller, your batteries are smaller, they last longer. That alone might be an argument, especially in the pre-hospital setting where you got to carry all this shit with you, to argue for having a biphasic. The problem is it then got, the rumor mill came along and said, you know what, it's not only smaller and easier to carry, but the outcomes are better. And that really, there was no data really to support that argument. Yes, they're smaller machines, yes, the batteries last longer, but there's no evidence to support that you'll get better resuscitation. So the next few articles looked at biphasic compared to monophasic. Article 22, 23, and 24. Article 22 was out of Holland. They gave them either monophasic or biphasic AEDs. They looked at all these cardiac arrest patients, and they found no really difference in their return to spontaneous circulation, hospital admissions, hospital discharges, anything like that compared to the biphasic. Article number 23 was out of Toronto. Same thing. They actually got people a little bit better back with an organizable rhythm. But again, no patient actually walked out of the hospital any better with a biphasic defibrillator. 24-hour survival, no difference. Hospital discharge, 30 days survival. Neurological outcome, no difference between the biphasics or the monophasics. And Article 24, same thing. They even looked, they had AEDs that arrived first that were monophasic or biphasic, and then paramedics showed up with the good old manual defibrillator, either monophasic or biphasic. They then looked at the patients who got both, the same type of equipment. I got a biphasic AED and a biphasic defibrillator by a real paramedic and found no difference. So there really seems to be no difference between the biphasic or the monophasic, but unfortunately the rumor mill is already out, and that's the way most places I think are kind of going. What about STEMI centers? People agree. I think that if...
Is, with the patient population getting so much heavier,
ooh, yeah. And where are you? Where do you work?
Here in Anchorage.
Okay. Big? What kind of population do we have here? About the average. Okay.
This was a particularly large gentleman who was in AFib, and I couldn't convert him at 360.
With a monophasic. Went up on it, yeah. I haven't seen any subgroup analysis in regard to weight of a patient, but it might be an argument.
Kilograms.
It works better.
Yes.
Okay, haven't seen any of that, but that's a valid argument. Yeah, yeah. So we should.
Which is the United States population.
Right, exactly. We're getting fatter and fatter, exactly. So everyone, I think, would agree that if you're having an MI, rather than thrombolytics, you'd rather have a cardiologist a cardiologist who knows what he's doing, right? You want somebody who's done a lot of these to actually go in there and open up your blood vessels. I think the data is fairly clear on that. And now, how many of you guys work where you have STEMI centers, where the paramedics actually bring you to, we started our STEMI centers in LA not that long ago, about a year and a half ago. And County USC just came up as a STEMI center about 6 months ago. So the question is it any better? Do you get better results by having the paramedics decide, hey, you're having a STEMI, and bringing you to, or with base station input potentially, that you can be brought to a PCI center, a STEMI center? So the first Article 25 was out of Holland. They looked at 467 patients. About 209 of them, they had an EMS diagnosis. They got transferred to a PCI hospital. 258 patients were actually diagnosed in the emergency department. And again, looking from symptom onset, not just door to balloon time, but symptom onset to MI diagnosis was shorter for the patients that got diagnosed by EMS. The symptom to balloon time, again, was shorter. PCI under 2 hours was more percentage of the patients that got diagnosed pre-hospitally, met the criteria of under 2 hours or 90 minutes, which is what we use in the U.S., and ED, and less so if they got diagnosed in the emergency department. Difference in regard to mortality at 30 days, really no difference. Dying at a year, again, no difference, or reinfarct by 1 year. Article 28 looks at the same thing. This is a national registry. They actually looked at door to balloon time. This was 56,000 patients in the national registry for myocardial infarction, about 60% of them getting thrombolytics, 40% getting PCI. And again, they found a difference, at least if the patient was brought in by EMS. They had faster times to thrombolytics, faster times to PCI, and higher percentages meeting within the recommended time frame for both thrombolytics and PCI, because we're kind of held to a standard of care. Article 29 was interesting. This was just kind of an observational study of all the MI patients that came in. This was in Italy. And they said, well, there's a big group that got diagnosed by EMS with a cardiologist input, and they got directly brought to a PCI center if they could be done within 90 minutes. Another big group are patients that walked into the PCI center saying, hi, I'm having my MI. And a whole other group that walked into a regular ER that then had to be transferred to the PCI center. And they looked at their outcomes, and they found the same thing. Time to treatment, mortality rates if you were in cardiogenic shock when you presented were much better if you got brought in by EMS and the people kind of had geared up and were ready for you, compared to if you got transferred to a PCI center. What was interesting is the same people who walked into a PCI center did worse than the people that were brought into the same center by EMS. So my thought here in this hospital is, same hospital, is if you walk in with your MI, if I worked there, I'd probably tell the person, you know what, go outside, call 911, because if you come in with a paramedic attached to you, you'll probably have a better outcome than if you just walk in our door. At least it seems like that from the data. Same article number 30, same thing, patients brought in by EMS, stuff got rigged faster, and the patients had at least, door to balloon time, that kind of stuff was about faster. What they don't find is big difference in like 30-day mortality and stuff like that. But at least getting door to balloon time seems to be a bit faster if you have them coming by EMS. Same for article number 31, was out of Canada. Article 32 looks at the issue of having paramedics give thrombolytics. Do any of you guys have paramedics giving thrombolytics? It seems that places where it seemed would make sense if you could do it safely is where if your transport times were ridiculously long. Most of us, I think, work in areas where transport times are within a few minutes. So having paramedics started in the field just seems super dangerous. But this was Article 32. Paramedics were trained, this is out of Ottawa, Canada. Paramedics were trained in kind of a STEMI tool, how to diagnose STEMI, what were the indications, contraindications for thrombolytics. They were then given 411 hypothetical cases. They identified correctly the STEMIs in 63 patients. They missed the STEMIs in 3 patients, but they falsely called a STEMI in about 13 patients, not an insignificant number. They still said their sensitivity and specificity were really good in their decision to give thrombolytics again, but they didn't talk about the benefits. What's the benefit of giving a thrombolytic a few minutes earlier? They didn't talk about transport times or any of that. So, again, if you let the EMS directors do what they want, a lot of them are going to want to do a lot of stuff in the field because that's all they're about. But in regard to hard data, whether it's beneficial to give the thrombolytics a few minutes earlier than on arrival to the hospital, no one's really shown that. And the last articles really look at kind of ACLS drugs. No one's really proven. What we've shown so far is that you got to do CPR early. You got to get AEDs to the patients quickly. Having the community educated more about CPR. Most of our communities, patients get no bystander CPR, so we got to do better training in that. What about patients that actually receive ACLS drugs? Once you start giving patients drugs, you know their outcome is going to be a lot worse just because they haven't. If they're going to be resuscitated and have good neurological outcome, they're usually resuscitated in the first few minutes or with good old defibrillation. So Ian Steele out of Article 32 was kind of a landmark article. This was the OPAL study, and basically looked at Ontario, 17 urban cities where they had not previously had any kind of advanced life support, intubations, IVs, drugs, that kind of stuff. They just had early defibrillation. So they looked at about a 12-month period, 1,300 patients who had just gotten rapid defibrillation. Then they instituted kind of this higher level ACLS in all of these areas, and they looked at the next 36 months, the next 3 years, care before and care after ACLS, and they really found no difference. They got patients a Roski back. They got them admitted to the hospital better if they had had advanced life support and got intubated and drugs. But in regard to walking out of the hospital, in regard to neurological outcomes, really there was no difference in regard to outcomes. So doing all this stuff that we do in the field, intubating, drugs, really doesn't seem to be that much more beneficial than good old AED and getting patients bystander CPR. The next few articles look at the issue of epinephrine versus vasopressin. We're now being pushed to give vasopressin, and there really isn't much good data to say that it's probably better. I think when American Heart adopted it, I think it was based on one study of 40 patients that looked like it was better, and American Heart kind of adopted it de novo. Article number 35 looked at a multi-center European study, looked at IV epinephrine 1 milligram compared to IV vasopressin 40 milligrams. It was repeated in 3 minutes and basically really found no difference. The hospital discharge, if you were in VFib or PEA or asystole, really show no difference. There's a little bit better if you're in asystole that you get a pulse back. But do you walk out of the hospital better? Most of the studies don't show any difference. Doesn't matter what rhythm you're in. Article 36 was basically a review of 2 studies. 44 studies originally looked at. 2 were fairly relevant. One was a randomized trial of 40 patients getting epinephrine versus vasopressin. Again, really no difference between survival to discharge. And randomized control trial, of 200 patients in hospital, cardiac arrest, epinephrine versus vasopressin, no difference from survival to hospital discharge. And Article 37 looks at the same thing. This study gave epinephrine alone versus epinephrine and vasopressin. And they found, again, for patients with asystole, maybe you got a pulse back, you got Roski back. They didn't look at final outcomes. They just looked at these kind of surrogate markers. Did you get a pulse? Did you get some type of Roski back in the emergency department? Whether or not you finally got made it to admission, whether or not you finally walked out of the hospital as you were before you had your arrest, that really wasn't looked at. So you have to be careful when the hospital or when studies look at surrogate markers. And Article 38 looks at amiodarone. Again, we're kind of being pushed to use that. This was a study out of Helsinki where they give undiluted amiodarone. These patients had already gotten defibrillation. They'd already got CPR. They'd already gotten a dose of epinephrine. It was not randomized, that they just kind of decided, hey, you look sicker. It's not working. I'll give you some amiodarone. 180 patients, about half got amiodarone. Again, no difference in Roski, no difference in hospital admission, and no difference in survival to discharge. And the last article looks at the issue of bicarb and basically looked at IV bicarb compared to saline. This was a number of years ago, 94 to 98, and basically found if you were in arrest for more than 15 minutes, you had a little bit better survival, ED survival, getting you up to a hospital bed compared to if you didn't get bicarb. Whether or not you walked out of the hospital was not really talked about in this study. So it seems like the IV drugs that we give are not really all that beneficial or all that helpful. It's not going to turn somebody around completely, at least not the vast majority that we see with AEDs. So the key is with the CPR, faster, deeper, and keep your hands on the patient. Don't take them off as much as we're doing. So especially as an attending, it's nice when the residents are doing all the work and I can kind of stand back and objectify and say, make sure that the tube is in the right place and is somebody doing CPR correctly. So if you have that ability, kind of watch your colleagues, or if you're in a training center, really watch to see how much contact time we're doing with CPR. Getting people more trained. I like this idea that the American Heart has of the 20-minute class. I think more people, if they know about it, are going to do that. I think the kit was like $30 or something, not all that bad, and I'm going to actually try to do some training in our waiting room. And paramedics with STEMI centers, it sounds like at least getting the patients to the right center, and you could extrapolate this to stroke centers, and people argue whether or not having all these multi-centers is a good thing. We already have the precedent with trauma centers. We already have the centers, pediatric centers. whether or not we should be having STEMI centers and things like that. It sounds like it's probably a good thing for most patients who need the PCI, but people will argue back and forth whether or not it's a good thing to actually have it throughout EMS centers. That's it. Anybody else have any questions?